Hey, good morning, everyone, and welcome to Euronurse. We meet every Saturday at 9 a.m. Central Time. If you're joining us from YouTube or Facebook, great. Glad to have you on board. And hey, this week we just added LinkedIn Live. We're going to be going to LinkedIn also live with this. So great. Got lots of places for you to see us. Again, like, subscribe, follow, share, all those good things. You know what to do. If this is your first time joining us, be sure to check out our website at uronurse.com. That's the best place to find out more about the show. And it's also the best place to go to see any of our past episodes. And yes, we've got 38 episodes that you can check out. Lots of good education out there for you. If you'd like to know more about how you could sponsor the program, click that little button that says sponsor info, and we'll give you some information on that. And no matter how you're watching us live, you are the ones that drive this program. It's your questions, your comments that we tend to talk about, and this is no different. And all of the formats, I'm not sure about LinkedIn yet because we're trying it out for the first time. If anybody's watching on LinkedIn, send me a comment. If there's a comment box, that'll let me know if it works. Otherwise, all the rest of you, I know for a fact that YouTube comments, Facebook comments, StreamYard comments, all of those work. Send comments, questions, anything you want, just go ahead and send it to me. We'll be watching for those to come up soon. This week, it's going to be me talking, and we're taking a deep dive into urodynamics. Now, with urodynamics, I gave a talk about 2 weeks ago at our local chapter meeting on urodynamics, so I'm really prepped for it. But the one thing I did realize, and the difference between the format that we use typically, which is our, the format that you go to a conference, you sit there and, it's several hours, and each speaker is probably talking for about an hour. And that's what I was doing. So I had an hour to give all the information I could about urodynamics. And I tried to give a lot of information, definitely, but I do know that I was kind of breezing over a lot of it. And I thought, that's the one thing I really like about Euronurse is the fact that we can go ahead and take that deep dive into the subject matter. And that's why we're here. So I, again, have the free, the favorite stories, general questions, comments, shout outs. We always start our show with taking some general questions. Just like to bring those up. Little different than what most people might have been used to with the format where I always have a group of experts on with me. Today I'm by myself. Yes, this is the AUA in Chicago, and we've got all of our panelists that are typically on are attending the AUA. So, hey, good shout out to them. And actually, I see Andrea Strong just said, good morning, LinkedIn Live on Euronurse. Oh, great. So I know it's working. Appreciate you doing that. So that's great. And then Shirley Abbott's looking forward to learning. Our office will be starting this soon. So, hey, Shirley, this is a great place to go. This is where you want to be to learn about urodynamics for sure. So I don't really have any great favorite stories to offer today. And I do know that we've got a lot of content to cover today. So I'm going to try to, get through this and really, again, take the deep dive. But if you guys have any comments or concerns out there, go ahead, please post those. Again, running the show by myself, I've got to try to watch for all these things coming up, but we'll see how it works. I will say that I would like to try to make this a little bit more interactive. So live audience, I'm going to ask a few questions. So if you're out there and you've got the answers or feel like answering, please do, because it'll make the show more fun instead of just listening to me talk for the next half hour, 40 minutes, whatever it ends up running. I did say I'm going to break this into 2 sections. I think at least 2, I can cover everything. So this is really going to concentrate on urodynamics, how you perform it, what you need to know to do a good test. The second, we're going to go into how you actually look at these studies and interpreting them. There's a lot of subtleties to the interpretation, and I think that it's a good thing to try to go in and discuss what things show up on urodynamics that are unusual and how I would interpret those. And again, we'll open it up to any audience members that have questions when we're going through things. I think I'll be able to see the comments as we're going along, so feel free to put any questions in as we go. I'm going to go ahead and make a few switches here. So bear with me as I get this thing out of here. And I'm going to switch over to our show right now. And there, hey, that worked. I'm actually in the picture. That's what I wanted to do. So let's take our deep dive into urodynamics, part one. Again, for those that may not know who I am, if you're new to the program, my name is Vic Senese. I'm a registered nurse, been in urology for, 30, I quit counting after 30 years. So I've been involved in urology for a long time and did urodynamics for many, many of those years. So I've done, literally thousands and thousands and thousands of cases. I never really kept track, but it was a lot. I can tell you that. So I'm going to try to share that great knowledge I have with you right now. So let's start off our deep dive. So I think one of the first things we need to talk about is what qualifications do you need to do urodynamics? And if you go and you do a Google search on that, you'll find out, according to Google at least, you should probably have a master's degree in urology or a bachelor's degree in physical science, such as nursing, or engineering field. And it makes sense. There's a lot of engineering type things that we look at. Or completed a residency in urology. So that's what they say in the US, most people that are doing urodynamics would have as a qualification. Now, the company that makes the equipment for this, or one of the companies, says that you need to have 6 months or more experience in basic science and take their 2.5-day course. So basically, I think pretty much we have all sorts of degrees out there doing urodynamics. And I'm not here to debate who should be doing it and why, one degree is probably better than other. But we do acknowledge the fact that people are doing urodynamics with all different educational backgrounds. I think the important thing is, if you don't want to, if you want to have a good study, you need to understand some basic principles behind the procedure. And that's what we're going to go into today. So I applaud everybody here that's joining us, because that means you are interested. And I know a lot of them are going to be watching this on demand too. So, all right. So one of the first basic things is just, how does the bladder work? So typically the bladder fills, and the early model suggested that the bladder would send a signal to the spinal cord, and it was almost like a reflexive arc, where they would just kind of spin back. As the bladder fills, it would empty. Always kind of what they thought is why you can't train children to potty train until they get to be older, because they don't have that control mechanism. It's just almost a reflexive arc. But thanks to the work of Claire Fowler, a British physician, we know more about how the actual neurology is affecting how the system really works. She did a lot of great research. Actually, she introduced a subspecialty called uroneurology, and she's credited it with that because of her great research that she did. So let's dive into a little bit more sensible way of how the neurology works for this. So we have our bladder, again, filling up with urine, and it sends a signal, but not just to the spinal cord. It actually has to go up to the brain stem. And if you think about it, the way a bladder works is it has to squeeze the urine out at the same time. Get my hands in this. It has to relax the sphincter. So it's try to get myself in this. It's a squeeze, relax. It's like, patting your head and rubbing your stomach. But it's coordinated. So it takes the brainstem to do that coordination. And that's exactly what happens. So the brain sends a coordinated signal for the bladder to contract while the sphincter relaxes. We get urination. Now, of course, to this model would have all of us probably wetting ourselves before I get through with this talk, which is not a good thing. So it's a little bit more complicated. And what we really found out from Claire's research is that there's many parts of the brain that are involved in urination. Two areas that I'm going to really concentrate on are this periaqueductal gray area and the premotor cortex. So we'll take a deeper dive into that right now. So again, bladder fills up, sends a signal to the brain stem. It's at this point that this periaqueductal gray area takes over. Now, this is the involuntary part of urination. This area is kind of like a relay station. It monitors the signal. So as the signal strength keeps building and building and building, what eventually is going to happen is it's going to start to send that information forward to the premotor cortex. Now, this is what's involved with voluntary control of urination. So it sends us forward as a sensation. Now, most of us, until our bladder reaches a certain level, have no idea that their bladder's filling. It's not till this relay station, the periaqueductal gray area, sends that signal forward, and we suddenly consciously know, hey, our bladder's getting kind of full. And when we're in the right arena, you know, a bathroom preferably, or the woods, you go ahead and say, hey, it's okay, I need to empty my bladder, it's really full, and you go ahead and empty your bladder. It's all under voluntary control at that point, or should be. So we're going to talk about when it's not. Now, before you get that deer in the headlight look, I know it's a lot of neurology that we just kind of covered, and that's never fun, but we're going to try to break this down into what we need to know, what we need to understand. But the important thing is to keep in mind, it's just not enough to examine the bladder without keeping in our head all the things that are involved as far as the brain goes. And, you know, decisions are made by the brain. So things that affect the brain can affect the urodynamics. And all these different responses happening are going to affect your study. So keep that in the back of your head. All right. So what's the bladder do for a living? It does two things. Stores urine, gets rid of urine. Storage and emptying. Now, let's take a problem like incontinence. And here's a time to get a little interactive. So patient comes in with incontinence. Is it a storage problem? Is it an emptying problem? Feel free to type this into your comments section. What do you think? Storage problem, emptying problem? Could be either one. Now, I do know there's a slight delay on the feed, so I'll give it a second or two to see if anybody's going to answer out there. Hello, audience. Hey, April McGriff just sent this in. I got somebody who knows what she's talking about. I agree. It's both. So it can be storage, overactive bladder, stress leakage. That would be a storage problem. How would it be an emptying problem? Well, BPH causes the bladder to sometimes overflow incontinence. So spinal cord injury, the same thing. You'd have overflow incontinence. So, hey, April, going to the top of the class. So how do we decide? How do we figure this out? Well, that's, of course, why we're here. That's urodynamics. Now, just a minute, buckaroo. Does everybody need urodynamic testing? And the question to that is no. There's a lot of good tests that can be done and should be done prior to putting somebody through urodynamics. Urodynamics is it's an invasive study. These are non-invasive things that can be done. Simple urinalysis. You know, if a patient has a urinary tract infection, chances are they're going to be going more frequently. Anybody who's ever experienced one knows. 3-day voiding diary. Audience, how many of you do 3-day voiding diaries? Just go ahead, throw it in the comment if you do. Let me know. I think it's one of the most underutilized tests that can really give a lot of information. I've seen patients fill out the voiding diary, and suddenly you find out they're drinking, a gallon of fluid, but they have no concept that gallon of fluid is going to cause issues with their urination, that they're going to urinate more frequently. I mean, most of us think you would know that, but they don't. I do see sometimes. Susie said she sometimes does it. Neil says plenty of 3-day voiding diaries. Great, Neil. That's the way to do it. A lot of information, bladder irritants. Sometimes you can see what they're taking. Big coffee drinkers probably going more frequently due to the irritation effect of caffeine on some bladders, not all bladders. Comprehensive history, and I'm talking about get a good history of what's going on with patients, urinary problems. Then flow rate and post-void residual are two tests that can be done separate from urodynamics, even though they are urodynamic tests, but they're very non-invasive, especially post-void residual done with the ultrasound. So again, a lot of information. Get that information first, and then decide who really needs to have urodynamics. Now, here's a good example. If a patient comes in with urinary retention, this poor guy can't pee, but is it BPH, which can be treated, or is it an atonic bladder, which isn't going to succeed? If those tests that we just talked about before are not going to give you a clear picture, and you're probably going to take this guy to surgery, that's a good reason to do urodynamic testing, so that you don't put somebody through an operation like TUR, and then they still have to have a catheter in. At least they should know that there's chances are that this procedure will not help them void. Now, the American Urologic Association, AUA, and SUFU, the Society for Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction, now I know why they call themselves SUFU, got together and they listed 5 categories that they felt were appropriate for doing urodynamics: identifying lower urinary tract dysfunction, predicting the consequences of lower urinary tract dysfunction on the upper urinary tract. That's really important. What's this doing to the kidneys? Predicting outcomes for management, assessing the outcomes of an intervention, and treatment failure. So if you did the test and they couldn't, or you did the procedure, the surgery, and they can't urinate, maybe you want to find out, is the bladder not working? I would like to find that out first, especially if I'm the one going through the surgery. So let's talk about urodynamics. And before we get into urodynamics, what issues affect testing? So the urodynamics is a test. It's not the normal thing that we, go through with our normal urination. And, it's all this stuff affects our cells. We talked about how the brain is working in the background. Cortical and emotional factors, variabilities in these factors, all can lead to variabilities in our urodynamics. So we need to try to isolate as much of that as we can out. Now, if your urodynamic office setup looks like this, I don't think you're going to get very good results. There is something called periuresis. Those that aren't familiar with it, it's also known as shy bladder syndrome. Those of you that are not in Chicago, this is the men's room from the Chicago, from Wrigley Fields, of the home of the Chicago Cubs, where they have these troughs of urinals where men just line up shoulder to shoulder for a nice social urination. And I can tell you, if you have periuresis, it's not going to be an easy thing to go. And keep that in mind. You want to try to make sure that your setup in your office allows for some level of privacy, because you're going to get better results if the patient's comfortable during the procedure. Now, fill time. Normally, a bladder is going to take about 2 to 4 hours to fill up on its own, with normal consumption of fluids, etc. But in urodynamics, we don't take 2 to 4 hours. It'd be nice. I mean, you'd get a better test result, but the reality is that we're spending more like 10 to 20 minutes on our testing. Fill time, from 10 to 20 minutes, which is much quicker. Does that cause some reactions? Does bladders start to contract because of the time that you fill it? Probably. And remember, just like an EKG is a snapshot of what's going on in the heart, urodynamics is a snapshot of what's going on in the bladder. And sometimes it makes sense to have longer studies, like they do Holter monitors to monitor a heart if they're not seeing what they want to see. There is some investigational things going on where we can monitor bladders long-term. This is a device that's put out by a company. It's under investigational studies right now, but as you can see, it's put inside the bladder. It's a little catheter monitor that's able to send over radio signals to a phone. What's happening is the bladder's filling up and as it's emptying. And you can put this in with a uroflow and get a uroflow pressure study. Really kind of very natural. We're not overfilling it quickly. So, excuse me, this is ideal. I think I'll be looking forward to seeing some of these results when this hits the market. Might be somebody good to have on UroNurse. So what's the first thing you should do when you're getting ready to do a urodynamic study? Read the chart. Important to know what's going on with the patient. And a lot of the medical problems out there do affect voiding. There's one I put in red, and I'm going to take a little bit of a deep dive on complete spinal cord injuries. If you're taking care of patients with spinal cord injury and you're doing urodynamics on them, you better understand what you're doing, because it can be a dangerous, not just a bad, a result, but you can have some dangerous things happen. If you've never heard the term autonomic dysreflexia, don't do spinal cord injury patients. You need to be familiar. We'll take a deep dive here and go into what's basically happening. But as the bladder starts to fill, those stretch sensors send nervous impulses to the spinal cord. The when it reaches the level of T6, sympathetic neurons become activated and release chemicals called norepinephrine. Norepinephrine causes blood vessels in the skin and abdomen to constrict, causing a rise in blood pressure. That rise in blood pressure is detected by sensors in the heart and neck called baroreceptors. These then send signals to the brain. So the brain then sends a signal. There's two ways actually the brain can oppose this blood pressure. One, it sends a signal to the heart to slow down through the parasympathetic vagus nerve that tells it to slow down. But when that's not working, it's also going to send messages down the spinal cord telling the blood vessels to start dilating. However, in spinal cord injury, we know that message never gets down to the lower level, so blood pressure continues to rise. Now, this rise in blood pressure is what's the concern. Sudden increase in blood pressure is a medical emergency that can lead to seizure, stroke, and even death. So once again, if you're not familiar with the signs and symptoms of autonomic dysreflexia, don't be doing the test. And if you're not familiar with how to treat it if it happens, again, don't even get involved in the test. Know your limitations. That's the most important thing. However, if you want to learn more about autonomic dysreflexia, Dr. Strong did a really nice talk on autonomic dysreflexia on episode 17, available on UroNurse. So check that episode out. Second thing you should do is always confirm their date of birth. I can't tell you how many times I brought a patient back to the room and I say, what's your date of birth? And I don't say, is your date of birth April 6th? I say, what's your date of birth? And then it's not right. Could be a chart error. I've had that happen. But a lot of times patients are just nervous, so they don't bother to they don't hear it properly. I don't know. Anxiety, has an effect. And you got the wrong person there. You don't want to run through a whole urodynamic test and find out you got the wrong patient. So always confirm it. Also, I like to confirm allergies. Mostly, don't put an open question like, do you have any allergies? And they go, no. No, ask them about this particular thing. Are you allergic to tape? Because we're going to be using adhesives. Are you allergic to the cleaning solution if you're using BZK or betadine or whatever? Make sure they're not allergic to these products. Are you allergic to latex if you have latex in your system? Always check those allergies out. And I always like to tell the patient who I am and what I am, kind of give them an explanation. Hey, my name is Vic Senese. I'm a registered nurse. I'm going to be doing your urodynamic test. I think puts patients' mind at ease if they know who it is. And then explain what you're going to do. My technique, what I like to do, I explain as I go along. I always tell the patient right out, first thing, I said, I'm going to explain everything that we're going to do. So no surprises, but we'll explain it as we go along. I think it's just a better way to do it. And I'm just going to throw in some of these questions as I see things coming up. Got a comment here from Frank Senese. I usually ask if they're allergic to shellfish to rule out the iodine allergy. Yeah, good point. Again, always ask the question specific instead of just kind of a broad question. It's just patients are nervous, and until you've been at that point, you don't know. So let's go into our very first test that we do, Uroflow. Uroflow is a nice test because it can be done almost naturally. You have some systems that can be set up in a urinal like you see here. Most of them, at least, they're set up in a commode, but they can be done in total privacy. There's no tubes inside the patient. You're going to get some good, definite information. And what we're looking for is what's called the Qmax, or the peak of the flow. So that very first one is a normal urination. We see the stream coming up, and then after they empty, it goes down. It hits a certain max. The norm for patients should be 12 cc's per second or greater. That's the normal speed. And now compare that if we see this study down here where we see this lower speed, and it's kind of a prolonged urination, is taking longer to urinate. That, to me, it looks like it's probably obstruction before I even do the test. And then down here, we see this intermittent stream. They're voiding a little bit, down they don't, and start again, start and stop. Again, could be due to enlarged prostate, could be some other issues. But at least you get a general feel of what's going on. The second test, now we just had them urinate into the system, get a urinalysis, check that urine. We're looking for infection. You want to make sure they're not infected before they go through with, you start doing the test and putting these catheters and tubes in. Generally, not recommended to do a urodynamics test on a patient that has an active infection. Number one, the infection is going to certainly probably interrupt or affect the outcome of your test. So that's a bad thing. Number two, you don't want to have somebody get more sick because you instrumented them with an active infection. I always say that if you're not somebody who has, a license to diagnose and prescribe for urinary tract infections, ask whoever's ordering the test, do you want this done? And the UA machines give out good information. The leukocytes are positive, nitrites are positive. That's a good sign there could be an infection. But I always like to look under a microscope. We have one. I know how to read a urinalysis, so I do it myself. If you have that, that's even better. If you see active bacteria, sometimes these tests can be fooled. But when in doubt, best to get a culture and find out and have the patient treated before you do this. Now, some people might say, well, how do you get a good sample from your system? Because you might have contamination from the prior patient. Well, that's a good point. You have to reprocess this equipment. Now, some of the stuff is use it once and toss it, like the little pitcher that the urine collects into. Some of it, like the commode, doesn't allow for that. And there are some really good products out there called high-level disinfection products. I like these spray foams that you spray on, that you follow whatever one you're using, talk to your supply person. But you can spray down that funnel and let the foam sit, and it'll wipe out and kill any organisms. So you want to make sure that, we're not having any cross contamination between patients. So you've done that. The next test is to do a post-void residual. And I show a self-cath that's a 14 French. The color of the tip always is a tip off as to what size the catheter is. My favorite one, straight 14 French, not a coude. And that allows me to kind of see if there's any strictures or narrowing of the passageway. Is there going to be a problem getting that catheter in? And the one thing I'll warn you is that the catheters that you place for the urodynamics are very small. You can do a lot more damage with a small catheter than you could ever do with a large catheter. The small catheter is small enough that it can puncture and poke into things like prostate tissue and stuff. So it's going with the bigger catheter, the 14 French. If you can't get it in, find someone with more experience to see if that's the problem. I would say if you're dealing with a male and the 14 doesn't go in, get a coude, see if that's just a prostate issue you're having. The coude goes in, great. They make these testing catheters in a coude. Use a coude. So now we're ready to start our test. We're going to be placing a catheter in the bladder. That's going to measure the pressure of the detrusor. Also, it's going to allow you to fill the bladder. Most in the old days, you had two catheters you had to put in, one for filling, one for pressure measurement. Now you don't. It's usually done in the same one. And then you need to place another pressure sensor somewhere else. Vaginal for female works out really fine. Otherwise, rectal sensors are where most the other ones are placed, obviously for male. You need to have an outside reference so that you can see what's going on in the bladder versus what's just happening, from pressure like a cough or something. So we've got those two placed. Here's another word of caution. Placing the rectal or vaginal sensor. Again, these are small catheters. You might think because it's small, you can just kind of gingerly, place it through the rectum, but you can have some internal hemorrhoids and you can poke a hemorrhoid. And, patients don't have to stop blood thinners to have urodynamics. So if they're on blood thinners and you poke something with that little catheter, they start bleeding, you're going to, have a real mess on your hands. So I always find a good, well lubricated finger, put that right on the tip of your finger, like I show here in the picture, and use your finger to guide it. You're going to be much better off. And you want to make sure you get that past the sphincter. Otherwise, you're going to get a lot of noise from the sphincter area. And then the last thing we do is put on what's called sphincter EMG. So these are usually done with these little sticky tabs that you see over on the left side of the screen. However, if you're doing spinal cord injury, it's best to get the needle electrodes and have those placed right next to the sphincter. You'll get a better reading, because what they're reading is especially the little sticky ones, they're just reading the muscles around being mobilized as things increase. But for just typical screening, that's probably reasonable. So now we're going to go into our actual filling CMG, or the storage. This is what we're looking at when we see how it's storing. And what we look for is capacity, compliance, competence of the sphincter, sensations, and detrusor response, which used to be called stability. I like the term stability myself, but let's stick with the common, what people are doing now. So let's talk about filling. First of all, how fast should you fill a bladder? It does matter. As I mentioned, normally we're trying to get this done in not 2 to 4 hours, but you should keep it to a lower pressure, a lower speed, like 20 to 30 cc's per minute. All the machines have you a way of adjusting those so that you're not, sending it in too fast. But start slow, kind of watch what's happening. I always say, I kind of favor the 20 at the max. Now, the other thing I'm going to tell you is I've done a lot of urodynamics. Twice in my career, I've managed to catheterize the ureter, just like a stent, was able to put it up there. I always start my urodynamics at 10 cc's or less. Whatever your slowest kind of testing speed is, that's where I would recommend. If you go ahead and start it at 20 or 30 cc's and you've catheterized the ureter, your patient's going to look like this. It's going to cause pain. It's like renal colic hitting. If it happens, no disaster. Just pull that thing back and get it back into the bladder and go on with your study. Just pull back and you'll just start it up again slowly and see if they have any pain. Now, those of us that have done urodynamics in the past, there's always been this controversy about to zero it or not to zero it when it's inside the patient. There's two types of sensors that are typically used. I know a few people out there still use the water-based ones. I used to do the water-based. You always had to zero that to atmospheric pressure. And then you had to make sure that when you use that, it was always placed at the level of the symphysis, so that it was like at the bladder level the whole time. So you had to almost like tape it to the patient. Much more difficult to use. The air charge, if you're using air charge, much easier. You can put those, the sensors don't matter. They're at the tip and they always get good readings. If you're using the air-based, I typically zero those inside the patient. It really doesn't matter where you do it. If you want to take the true reading of what the pressure, because there's abdominal pressure, that's what people that argue that you shouldn't zero it are trying to read. Just do it consistently. And most importantly is make sure that this reading here, the P det is reading 0. For those of you that may be new to urodynamics, we see 3 channels here. P vest, that's the catheter that's inside the bladder. P abdominal is the one that's in probably the rectum. And the one that says P detrusor is the machine actually doing the math, subtracting one from the other. So we kind of call that the true detrusor reading. So it takes out anything that the patient may be producing by coughing, sneezing, moving, whatever. Speaking of coughing, so if you're getting ready to do a urodynamic test, rookie mistake, you go and you plug everything in, you start the test, and I'm guilty of it myself. I've done it. Forgot to charge the air charge catheter, ran a whole test and didn't even know it. Always start by having the patient cough. You want to see these spikes. You want to see them on the study so that whoever's reading the study later on will see that those are there. But always start off with that cough part. So a couple coughs, you see that shown there. And of course, it should not show up in the detrusor. That should kind of erase itself. So that tells you you're going to have a good study. First thing we look at is compliance. How stretchy is the bladder? I always say that a bladder it's kind of like a balloon. If you're blowing up a normal balloon, that's a normal bladder. You're blowing up those balloon animals, that's a low compliant bladder. And of course, if you're blowing up a punching ball, that's overly compliant. And compliance is measured by simply filling the bladder and watching what happens to P detrusor, how much rise happens in the detrusor. Now, a normal compliant bladder, good normal stretchy bladder, should almost be flat. Should be just like nice flat line. You can do a mathematics to kind of get a calculation. You divide the volume change by the change in detrusor, And if it's greater than or equal to 20, it's normal. If it's less than 10, it's low. So here we go. We can see that we did the math, and it went after 100 cc's, it went up 5, so that's 20. So it's a normal compliance. And then here, this bladder wasn't. It went up by 10, so that only equals 10. So our number shows that it was low compliance. Of course, it didn't go up at all. That's probably overly compliant. Different than sensations, by the way. You know, you're looking at how much stretch there is to the bladder. It doesn't mean the patient didn't feel it. The patient could have felt it. Maybe they didn't. Why do we look at compliance? Well, the other thing we look at is what at capacity is the maximum pressure inside the bladder. The bladder is a very important part of protecting the kidneys. So it's a low pressure area. Now, I'm not talking about the pressure when it's squeezing the void. I'm talking about resting pressure at capacity. It should never go above 19 centimeters of water. So 0 to 19 is normal. And here's why. Because at 20 to 30 centimeters, there's a slight risk that you could put the upper tract at distress, the kidneys. At 30 to 40, that risk becomes moderate. And over 40, it's imminent risk of upper tract distress. So if somebody's sitting around and they've got high pressures in their bladder, they could end up causing permanent kidney damage. This was one of the problems with some spinal cord injury, why a lot of the spinal cord injury patients died so early or had renal failure from it, was because of this high pressure system always sitting there affected the kidneys. So sensations, we fill the bladder. We ask the patient, hey, let us know when you feel like you got to urinate. Until you reach a certain point, you won't even really know your bladder's filling up. At about 90 to 100, you'll start to get a sensation. And at somewhere around 200 to 400, you're going to have a stronger urge to urinate. You'll probably say, you know, if I was in a car, I'd probably start looking for the bathroom. And then at some point, between 300 to 600, you don't want to wait very long. It's got to go now. And that's where usually you have them empty their bladder. You switch over to this emptying stage. Sensory urgency. Sometimes they get increased bladder sensations, early sensations. Without leakage, that's considered sensory urgency. Sometimes they have reduced or delayed sensations. They don't start feeling their bladder fill till 400 or 500 cc's. That would be a reduced bladder sensation. And then no sensation, that's kind of self-explanatory, but they just don't feel their bladder ever fill up. Which brings me to the question, if you're doing urodynamics, how far should you fill a bladder? Anybody wants to throw it out there? Do you stop at 500? Do you stop at 750? Do you stop at 1,000? More? Anybody want to take a guess? I'm going to try to clear up some of my comments here so I can see if anybody puts a guess in here. Sorry, just cleaning up. I don't see anybody willing to take a guess. They've got a lot of people watching, so I'm surprised. Nobody wants to guess. 500. April took a guess. I like April's guess. 500. My answer to this is read the chart. So I say that because what if the patient came into the emergency room, had a catheter placed because they couldn't urinate, and they got 1,000 cc's out? That's a patient I would probably fill up beyond the 500. But most patients I wouldn't go beyond 500. And Susie, you are right. No more than 1,000. I would never hang a second bottle on anybody. Most of the time, I'm 700. That's if I saw somebody who was in retention, didn't have any sensations, I'll push it maybe that far. But hey, thanks for the comments in there. What's the significance of early sensations? It's usually associated with an overactive bladder. The significance of delayed sensation were all those medical problems that I mentioned earlier. They all affect the nerves. It's why the nerves are important. Anything that's affecting the nervous system can affect the sensations. So stability. What's stability? Well, that's how the bladder behaves as it fills. Now we see here these little jumps in the detrusor. We're not seeing them in the abdomen, so we know it's not somebody coughing. We see it in the detrusor, the pDet channel. So that means the bladder actually contracted. That's not how it should work. Bladder should never contract during filling. And sometimes you'll see with the contraction, they'll even have a incontinence, a leakage of urine. So this is another example of stability. And this is what we really want to see. that nice flat line as it fills. Again, not coming up too high. You know, we don't see the number, you know, coming real high, but we see that nice flat line. Now, some might look at that line and say, well, that's really not a straight line. It's got a lot of little jagged things going on in there. Well, most of the systems, I think all the systems do have some kind of pump system. The ones that I use have one it has a spinning drum that's pumping. So it's not it's like a pulsating jet of liquid going in, not a steady flow stream. And what we're seeing is that little ratcheting is a sensitivity being picked up by the pump. Detrusor overactivity can be categorized into 5 different categories. So phasic, when it occurs during filling but doesn't cause incontinence. Terminal, when it occurs towards the end of near maximum bladder capacity. Compound, with an increase in detrusor and baseline detrusor pressure with each contraction during filling. That's typically like a neurological disorder. High and sustained involves continuous detrusor contractions with detrusor pressure not returning to baseline. And post-micturition. So sometimes after they void, you can sometimes see a spasm of the bladder. So you can categorize these in any of those 5 states, but mostly just marking that they have it. So sphincter competence is the stress incontinence test for cough, sneeze. You should not leak urine. And how do we test that? Well, I got an eyeball there because it's an eyeball study. If you've got one of these nice Senese chairs, you're lucky. They are really good for being able to get the patient up, because you have to get down there to look at the urethra itself when you have them doing some pressures increases to get a better look at it. And it should always be done with a moderate volume, like 150 to 200, that first sensation area where they're kind of just our first urge to urinate area, not capacity. And what you're doing is you're looking and you're having them Valsalva, kind of bear down. If some patients can't do that, you have to just, I do a light cough, you know, keep coughing harder. I don't have a cough. I'm just trying to demonstrate. But anyway, you want to watch this line and try, and you're reading the P vest, by the way, not the P detrusor, because that's going to take and subtract that out. So I look at the P vest and I want to see what it is. Now here I had a Valsalva, and we see there's no leakage. So I like to note where I don't see leakage, so that pressure. And then here we have a Valsalva, and we do see a leak. Now you can see that little, up on the top there, that little peak, that's the uroflow showing. Now somebody who did this by having the patient do this Valsalva over the uroflow machine. So when they saw it show up on the uroflow, that's how they marked it. I would never do this test that way. You want to get an eyeball, because it's going to happen before it hits the uroflow machine. So you want to get a more accurate reading. And then you're going to note what those are. I usually try to reproduce it, so you do see a couple more Valsalva maneuvers just to see. But you want to get that lowest point that it leaks. So what's the significance? Well, if it's less than 60 centimeters of pressure, they consider that intrinsic sphincter disorder. If it's so it's a sphincter problem. 60 to 90, it's kind of equivocal. And then over 90, they suspect urethral hypermobility. For those of you that are not familiar with hypermobility, normally when somebody coughs or sneezes, the urethra stays where it's at. It doesn't move, and the pressures is dissolved throughout the area, so that there is no leakage. But when the bladder is able to descend during a cough and the angle changes, it does allow for leakage. That's stress incontinence. One of the other things I need to mention is a lot of times when you're doing these, you're going to have patients with prolapse. This is a very mild prolapse. That arrow is just showing the urethra. That's where we're going to be eyeballing for leakage. But if they have prolapse, I would do the test with the prolapse, just like you see, and then get the Valsalva, get where they leak. And then you want to kind of, I think in this situation like that, I would take 2 fingers and push on either side, so I'm not compressing the urethra, and decompress that prolapse, push it back where it needs to be, because that's what the doc's going to do if he's going to do a repair. And then do the same thing. Sometimes you can do a stress test and there'll be no leakage with the prolapse. You get rid of the prolapse and then all of a sudden now they leak. That's significant, because if the doc's going to be doing a repair of the prolapse and it then unmasks stress incontinence, the patient needs to know that, the doc needs to know that, because they can vary the procedure for that. Now, sometimes the prolapse is, and we have some talks about pessaries and things that talk more about prolapse that you can check out on Urinars. But if it's a more grade 4, where it's really kind of completely outside the introitus of the vagina, those you almost have to reduce in order to do the test. You can't even usually get a catheter in. So usually I put those in and I pack them with something. I like to just use some well lubricated gauze pads to hold it in place, and then do the same thing, do the test for the stress leakage. We've done our filling, so now we're going to get to our emptying. The emptying phase is called the voiding flow pressure study. And normal voiding pressures between 10 to 40 centimeters of water. Whenever you're doing the test, always ask the patient how they void. You'd be surprised. Some men sit to void. Some women hover to void. So if they're sitting or standing, it should be done in whatever is normal for the patient. Again, always privacy makes a big difference. So if you can provide a good setting like this. One of the things I will caution, I've had some patients get a little lightheaded, kind of a vasovagal response because they got these tubes and stuff in. Make sure that they're really, ask the patient, do you feel okay? Everything's fine before you have them standing up to void. But if they are, it's the best way to do it for a man if that's how he voids. What we're looking at is this pressure versus the flow rate. And we can see, as I showed in that earlier curve, that you don't always get a perfect round circle, but you want to try to predict that area. Now the machine is going to read whatever the highest number is, and it's sometimes these jagged peaks which may not be the right thing to read. And then what you want to do is find that peak and kind of drop a line. Most of the machines allow you to put a marker in there, and you want to see what the pressure is and what the flow rate is, and compare those two. And what we see when I go and I kind of adjust for what the numbers that I see, it's really 40 cc's per second with a flow rate of 15 centimeters. Flow rate of 40 cc's per second with a pressure of 15 centimeters of water. And always take a look here where you're starting. If it's not at 0, make sure you take that out of your measurement. Now contrast that, which was a normal study, by the way, with this one here, where we see the flow rate is only 4 cc's, that little tiny bit up there, and 60 centimeters of water. Bladder's really squeezing hard to get the flow out. That's the definition of obstruction: high flow or low flow, high pressure. And some of the machines are able to produce this graph called the Abrams-Griffin nomogram, where it actually goes and puts out the a comparison of the pressure versus the speed. And if it's in the red zone, it's obstructed, yellow equivocal, and green's good. EMG, the last part we're going to talk about, is to measure how well the sphincter is working. Again, needles for generally if you're doing spinal cord injury, otherwise the pads. But basically what it's looking for is recruitment of motor units during bladder filling. So sphincter pressure should go up, or activity should go up as you fill. What we're trying to find out is when people void, is the sphincter relaxing? If they don't, that's called vesical sphincter dysinertia. And as we can see here from this particular chart, on the bottom is the EMG channel. Now you can really crank up the EMG, and this is what's shown here. It doesn't usually have to be turned up that high, but as we're filling up the bladder, we see the EMG is increasing. So that sphincter is working harder. That's what we want to see. Now over here, we see as the patient's trying to urinate, the EMG showing that the sphincter is working harder. That's not right. That's, again, that I talked about the coordination of voiding. So you got squeezing and relaxing. So we're not getting that. We're having squeezing and squeezing. And so now you're fighting and you're creating this kind of tug of war inside. That's dysinertia. That's what we're trying to test for with the sphincter EMG. And hey, we made it to the end of our study. So again, deep dive. I know we took a long time, but I am going to open this thing up to questions. So, whoops, sorry about that. I gotta switch over. Okay. So at this point, I will be glad to take any questions from the audience that you might have on urodynamics. I know even the deep dive, and we've only covered, half of the study, because now we got to start looking at these studies and trying to interpret them. We just saw a little bit about the studies. So again, we got the lion's share to still go, but I do open it up to all questions. I'm going to give you a little time to compose your thoughts. Feel free to put in any questions. I know we're running close to the end of the show. If you got comments too, I'm curious, how did you like this talk? Was it too much to cover, or seemed like I had enough time to cover? Because like I said, when I gave this talk, I covered a lot more information in only an hour. We spent about almost 40 minutes here. No, I'm sorry, almost 50 minutes here. I just looked at my clock. So again, questions? If not, I get off a little early today. I'm not used to being the only one talking either. Now I had to talk through this whole thing. All right, I'm starting to get some feedback. Hey, Frank, thanks for the comment. Great job, very informative. And again, anybody else has the desire to just send in a comment, feel free. I'm going to, yep, good. I just wanted to make sure I have my things set up right. Just give a little plug in for next week. Next week, we're going to have Dr. Michael Gerlnick joining us for the evaluation of the overactive bladder. So we're looking forward to that. Again, we do invite people, if you haven't had enough, there's going to be the after party. Just go to uronurse.com. If you've never been at the after party, it's a Zoom meeting. Just join us on Zoom. You can have an open mic, open video, and we can sit and chat. I'm going to go ahead and bring in some of these comments that have come in while I've been going here. Let's see here. Neil said, it was a good amount of information for the time you had to present. Thanks, Neil. Appreciate that. April, this was an excellent presentation. It's always good to get feedback. I'd like to hear that. Deborah says, thank you. As someone studying for the urologic nursing certification test, this is very helpful. Hey, and check out if you didn't catch last week's, Kathy Marchese spoke about certification and what's involved in getting certified. So I do welcome you to go ahead and check that out on UroNurse. And good luck on the test. I commented in that last week's talk that I took it twice, not because I failed it. I took it twice because back in the old days, you had to do a project to renew, and I didn't want to do a project. So I said, can I take the test again? They said, yeah, sure. So I did. So I passed it twice. Susie said, do you have cheat sheet with the normal rates versus abnormal rates? Susie, that's a good point. What I'm going to do is I will on UroNurse, I'll put down, what I'll do is I'll give you a copy of the slides. I'll put a PowerPoint, a handout for you to be able to get those numbers off, because I think it is helpful to have a lot of those numbers available. So we'll take care of it. Got you covered. And great information about urodynamics. Sorry if I ruined your name, but I'm going to say Raj. Thanks for great compliments. With that, I'm not seeing any more things come in, but hey, it's been really great. You guys are always great. I know we're going to have a lot of people watching this on post, only because our urodynamic, we did urodynamics early on when we first started UroNurse, and that's the highest rated show that we've had has been urodynamics. So I know that it's something that a lot of people are interested in. And again, I hope didn't offend anybody. I'm not trying to, make a point of who should and should not be doing urodynamics. What I am making a point of is that you got to do good urodynamics. We need to have studies that are worth doing, because the machine will spit out numbers, but those numbers can be pretty meaningless. And I kind of gave you a clue a little bit how you have to sometimes interpret what the machine is telling you, because it's important. If you just go by what the machine says, you're probably not getting good information. And some of the things that you're going to see in the next talk, which, oh, by the way, is going to be in a couple of weeks. I give it a couple of weeks because I want people on the on-demand audience to have a chance to watch it, because I'm hoping to get a big group for the next in 2 weeks when I do the second half. Again, to get some interaction from you guys with questions and things as we kind of go through the interpretation. We'll have a bunch of graphs and things from actual studies and talk about what does it show and how you read it and how you make out your formal report, because it's really, this urodynamics really, really, really depends on the person doing it to know what they're doing. Because if you just look at it's not like an x-ray where you just look at an x-ray and say, okay, that's a fractured bone. You have to see what happened during the test that may have caused this thing that's showing up on the urodynamics. So anyway, it's a tease for a couple weeks, so please join me again. For those of you that are interested in catching the after show, go ahead to that uronurse.com and hit that after party. And for those of you that aren't, it looks sunny out here in the Chicagoland area. So I'm going to go out and enjoy some of that after the after party. See everybody next week. Oh, and by the way, next week, I'll be coming to you remotely from from Florida. I'm going to be taking a drive from Miami to Key West. We're going to be going that whole long trail down there. So fingers crossed, everything should work just fine. I'm confident it will, but we will be coming remote. So it'll look maybe a little different. Might be out. I don't know. I might be outdoors doing it. So, all right. Well, last few comments. Shirley, thank you for watching. And Charlene, love the personal nursing tips you have shared through the urodynamics. Great. Hope to see some of you in the after party.